Member mic 1, 2, 3, test, test, test. Member mic test 1, 2, 3, 1, 2, 3.
The joint hearing of the Military Personnel Subcommittee and the, the Veterans Affairs Health Committee will come to order. I'm Jackie Spear, and we will now have a discussion on a very serious issue. I'd like to thank Chairwoman Brownlee for partnering with us on this incredibly tough issue. The statistics are staggering. There were 321 active duty suicides and 144 reserve component suicides in 2018. This is the highest number of suicides since 2012. An estimated 20 service members and veterans combined committed suicide a day. It is an epidemic, but it's more than an epidemic, and it's more than numbers. These are people's lives and the lives of their families that are impacted by it. And we have got to come up with a means by which we can address this in a holistic fashion. They're not numbers, but these are service members who were willing to die for our country, but took their own lives instead. Service members we failed. Behind each of them is a person and their family, friends, and comrades in arms. 2 weeks ago, I met with Patrick and Terry Casarada. Their son, Brandon, was an active duty sailor in the Navy. He had high aspirations for a Navy career, but something changed, and tragically, he took his life. His parents knew something was wrong, tried to intervene, and were turned away by the Navy. The request, so that other parents will not have to endure their grief and pain, was that Congress ensure that service members and veterans receive the help they need without fear of retribution. We must do everything we can to break the chain of suicide that has afflicted our military and veteran community. This problem could not be more urgent. The reason we're here meeting jointly, the subcommittee is responsible for tackling suicide in the DoD and VA, is because we need to treat service members and veteran suicide as one issue. Veterans are about twice as likely as civilians to commit suicide. Military service appears to be a casual pathway for increased suicide risk due to the access to and familiarity with firearms, post-traumatic stress syndrome, depression, loss of community, alienation, head injuries, and substance dependence. These factors take root, manifest, and worsen across an individual's DoD-VA experience. We need to correct this reality by preventing, detecting, and treating suicide risk from the moment an individual signs up to well after they leave the service. Today we'll hear from a panel of experts from the Department of Defense and the Department of Veterans Affairs to help us understand the scope and magnitude of the suicide challenge affecting our military and veterans communities. We will also learn about suicide prevention efforts within the Department of Defense and Department of Veterans Affairs and try to better understand ongoing collaborations and potential future partnerships related to suicide prevention efforts between the Department of Defense and the Department of Veterans Affairs to try and end the epidemic. Before I welcome the panel, I would like to ask if Ranking Member Kelly would like to say some introductory remarks.
Thank you, Madam Chairwoman. You know, I'd first like to say I've had the opportunity to command at the battalion level in combat, and I was in Iraq in 2005 as an operations officer, and we lost 29 soldiers in our formation, our brigade formation. Coming back in 6, we buried way too many in that year following who had survived the traumas of war and who came back and who are no longer with us. And so unless you've experienced that firsthand, it's difficult to understand the impact on the family and on the soldiers and on the hearts and minds of the community, knowing that they so bravely served this great nation and then came home and something went awry and we have to fix it. It is that important. I understand why we lose soldiers in combat. I cannot understand why we lose them when we get home. I wish to welcome our witnesses to today's hearing and want to thank them for being here. The fact that we're holding a joint hearing with both the Department of Defense and Department of Veterans Affairs testifying together underscores the importance of suicide prevention and the need for a unified solution to the problem. We're at a crisis point. Last year's suicide rate among active duty forces was the highest it's been since 2012 and ties for the highest on record since the services began tracking it. Meanwhile, approximately 20 veterans commit suicide each day. This is unacceptable, and we all have a responsibility to fix this issue. I'm concerned that the high rate of suicide among service members and veterans will soon become a fact of life, and that we are beginning to accept it as a natural consequence of military service. We cannot let that happen. We must take decisive action to disrupt the status quo and reverse this epidemic. When a service member takes his or her own life, it is a tragedy for both the surviving family and the unit. While suicide has an often irreparable effect on the service member's family, it can also cause lasting effects on the unit. In addition to the emotional impact on fellow service members, we know that one suicide in a unit can sometimes lead to additional suicides or the contagion effect. That is why suicide must continue to be treated as not just a personal mental health issue, but as a readiness issue. I'm interested to hear from today's witnesses about the behavioral health treatment available for service members and veterans. Particularly, I'm concerned that there continues to be a stigma associated with seeking behavioral health treatment. In fact, as the VA notes in their written statement, over half of those who die by suicide had no mental health diagnosis at the time of their deaths. I'm interested to hear how the services mandate periodic behavioral health checkups for all service members and whether those interventions are effective. Just like required yearly physicals and dental checkups are not an option, should a substantive session with a behavioral health provider, not just an assessment by a medical provider, be required? I'm also convinced that small unit leaders' involvement is critical to identifying behavioral health issues. The services must leverage the NCO leaders closest to the service members at the team and squad level to help identify self-destructive behaviors and get help for service members. I would like to know what training is provided to these leaders to help them in identifying problems and getting assistance. I hope that today's hearing will bring renewed attention to the problem of military suicide. While I'm interested in the actions that the Defense Department and VA have done to prevent suicide, I'm also focused on the practical things we can do today to reverse this disturbing trend. Thank you, Madam Chairman, and I yield back.
Thank you, Ranking Member Kelly. Now we're going to hear from Chairwoman Brownlee.
Thank you, Chairwoman Spear, and thank you for hosting us today. Your dedication to the prevention of suicide among not only veterans, but also our service members is evidenced by your willingness to host this joint hearing among our subcommittees. As a member of the Committee on Veteran Affairs, our jurisdiction is limited to the Department of Veteran Affairs. While we may inquire as to the activities of the Department of Defense, I cannot remember the last time we had the opportunity to receive testimony from the agency, so I thank the DoD for being here today. Despite this, the actions of the Department of Defense significantly impact the lives of our veterans. From the status of a service member's discharge to the location of a service member's service to the responsibilities of a service member while on duty, all of these decisions have been shown to impact the likelihood that a veteran will experience suicidality. According to VA, of the 20 veterans per day that die by suicide, nearly 4 are either active duty service members or members of the Guard that have never been activated, thus ineligible for VA health care. Yet VA is committed to reducing this staggering statistic through a public health approach. By identifying which individuals are most in need and targeting effective preventive interventions to those individuals while creating a system of health throughout the population as a whole, VA is ensuring our most vulnerable and high-risk veterans and service members are surrounded by the resources they need most. The quicker VA is able to identify those in need and connect them to resources, the more effective suicide prevention efforts will become. If the Department of Defense is willing to create a fluid movement of data between the two agencies, then the efforts of VA would only be magnified. VA would be able to identify high-risk service members before their transition is complete, and DoD would be better able to assist in ensuring vulnerable service members are aware of and have access to VA and community-provided resources that might reduce the turmoil caused by the service member's service and assist the veterans and his or her family as the veteran transitions home. For instance, VA offers a variety of counseling services to active duty service members, members of the Guard, veterans, and their families at vet centers throughout its readjustment counseling service. However, service members only make up about 5% of the population that vet centers serve. Also in 2017, Congress expanded eligibility for mental health care to certain veterans with other than honorable discharge statuses. However, 2 years later, we are seeing in the media that veterans have not been adequately notified of this benefit. While VA was ultimately tasked with sending letters to veterans that may be eligible under the expansion, there is no reason the Department of Defense could not assist in ensuring that these former service members are connected with the care they qualify for. Again, I'm thankful for today's opportunity to engage in this much-needed dialogue and hope it is the beginning of a productive relationship between our two committees and our two agencies. And I yield back, Madam Chair.
Thank you. Thank you, Chair. Now we'll hear from Ranking Member Dunn.
Thank you, Chairwoman Brownlee. Chairwoman Spryer, I'm grateful to be here this afternoon with my colleagues from the Committee on Veterans Affairs and the Committee on Armed Services to discuss the tragedy of suicide among service members and veterans. Joint hearings like this are not standard for Congress, but the fact that we're holding one here today is testament to our dedication to address this crisis. Congress has passed legislation and provided funding to stem the tide of suicide in military and veterans communities, but stubbornly, tragically, these rates have refused to budge. I'm hopeful that by bringing this subject matter experts from both departments here together and holding a conversation that crosses our jurisdictional boundaries of both committees, we'll be able to shed some new light on this complex topic and start saving lives among those who've served and are still serving. And I thank you, our witnesses, for joining us and our audience for joining us. And Madam Chair, I yield back.
Thank you, Ranking Member Dunn. I ask unanimous consent to allow members not on the subcommittee to participate in today's hearing and be allowed to ask questions after all subcommittee members have been recognized. Without objection. All right. Now we welcome our panel. Thank you all for joining us. Dr. Elizabeth Van Winkle is no stranger to this committee. Thank you for joining us. She's the Executive Director of the Office of Force Resiliency in the Department of Defense. Sitting next to her is Captain Mike Colston, MD, United States Navy Director of Mental Health Policy and Oversight at the Department. Next is Dr. Keita Franklin, National Director of Suicide Prevention at the Department of Veterans Affairs. And finally, Mr. Michael Fisher, Chief Readjustment Counseling Officer, Department of Veterans Affairs. Welcome to all of you. And I think we will start with Dr. Van Winkle.
Thank you. Madam Chairs Spear and Brownlee, Ranking Members Kelly and Dunn, and distinguished members of the subcommittees, thank you for the opportunity to appear before you today with our colleagues from the Department of Veterans Affairs to discuss the Department of Defense's suicide prevention efforts. As many of you are aware, I serve as the Executive Director of the Office of Force Resiliency, a portfolio that oversees several priority efforts, including the Defense Suicide Prevention Office, which we commonly refer to as DISPO. As many of you also know, the department recently announced a new director of DISPO, Dr. Karen Orvis. Unfortunately, Dr. Orvis was unable to attend today's hearing, but would be happy to meet with you or your staff moving forward. Today, I can discuss the department's efforts on suicide prevention from my role at Force Resiliency, where I oversee the department's policies on the prevention of suicide, sexual assault, harassment, hazing, bullying, and drug use. I also oversee the DoD VA Collaboration Office. In this position, I recognize the intersection of many of these difficult and challenging issues and work to align prevention efforts within this continuum. Although each of us at the witness table represents different efforts within both the DoD and VA, we are all committed to the same critical mission of suicide prevention. Both departments work in strong partnership. With me today is my colleague, Captain Mike Colston, the Director of the Mental Health Programs for Health Affairs. Captain Colston and I can discuss what we are currently doing within the department to prevent suicide in our ranks. We at the Department of Defense have vowed time and time again to ensure that we do everything possible to support our service members, and all of us work tirelessly to do just that. Yet our rates of suicide are devastating and unacceptable, and they're not going in the desired direction. Although our data helps drive and improve our efforts in this space, my colleagues and I know that every single life lost is a tragedy, and each one has a deeply personal story. With each death, we know there are families and often children with shattered lives. We cannot rest until we have pursued every opportunity to prevent this tragedy among our nation's bravest. We know this is a shared challenge. Nationwide, suicide rates are alarming and increasing. None of us has solved this issue, and no single case of suicide is identical to any other case. The scientific research surrounding prevention of suicides is both complex and ever-evolving. Suicide is the culmination of complex interactions between biological, social, and psychological factors operating at individual, community, and societal levels. Our data also tells us that it is often a sudden and impulsive act. To address this complexity, we leverage scientific evidence-informed practices to constantly pull every idea, every possible effective initiative into our toolkit to help service members and their families. We seek ideas and new solutions from everywhere, whether that's within the department or from stakeholders such as researchers outside of the government or within Centers for Disease Control and Prevention, and also from Congress. Indeed, your inputs and your engagement have been critical to our efforts. Because data informs our ability to take meaningful steps and fulfill our commitment to transparency with you and the American public, the department will soon expand our reporting on suicide-related data. This summer, we will publish our first annual suicide report, which will supplement our long-standing DoD suicide event report. We address this in our written testimony, and I'm happy to discuss any questions you may have about our reporting and how we use data to inform our research and initiatives in the area of suicide prevention. We are grateful for the opportunity to speak with you today. Suicide prevention is among the most complex challenges we face and one of the most devastating to bear. The root causes vary from one individual to another, and the signs are often difficult to detect for friends, family members, and even for clinicians who work so closely with many of these individuals. More than likely, each of us in this room has been impacted by suicide. Friends, family, loved ones, lost to this decision that will forever impact our lives, leaving us with far more questions than answers and a weight on our shoulder that often never recedes. Within the military community, this loss reverberates beyond the unit, beyond the commander, and beyond the service. It is a loss for our country and one we cannot afford and we should not accept. Many of you have heard me say this before, but we truly must show as much commitment and dedication to the well-being of our service members as they have demonstrated on the day they step forward to volunteer and serve our country. We must meet that sacred obligation because we need each and every woman and man who bravely signs up to fight for this nation. Those who choose to serve are an inspiration to us all. They are the front lines. We depend on them and we need them. We must fight for their safety at least as hard as they fight for ours. In closing, we thank you, chairwomen, ranking members, and the members of your subcommittees for your steadfast dedication and support of the women, men, and families who defend our great nation. I look forward to the discussion today.
Thank you, Dr. Van Winkle. Dr. Colson, do you have a, do not, okay. Let's move then to, is it Keita, did I pronounce it?
Yes.
Dr. Keita Franklin.
Good afternoon, Chairwoman Spear, Chairwoman Brownlee, and members of the subcommittees. I appreciate the opportunity to discuss the critical work that the VA is undertaking to prevent suicide among our nation's veterans. I am accompanied today by Mr. Michael Fisher, Chief Officer, Readjustment Counseling Service, who leads our Vet Center work. I've been in this permanent position since April of last year, but like many in the room today, the military has always been a significant aspect of my life. My father is a 20-year Navy veteran, and my husband is an Air Force veteran. Prior to joining the VA, I served as a director of the Defense Suicide Prevention Office, and my career has focused on deployment and trauma and how that impacts families and marital relationships. I'm a social worker by training, and I've focused on child welfare and have led various programs around domestic violence, sexual assault, substance abuse, and combat operational stress before narrowing in on suicide prevention. So this mission at the VA is both critical and personal to me, and I understand the urgency of it. At my level, I respond to text, emails, and phone calls from service members, veterans, and their family members who are seeking support. Just 2 weeks ago, I spent 2 days with one of our partners, the Independence Fund, and approximately 80 veterans who deployed together, and they faced an incredible amount of trauma in that deployment, the 3rd to the 67th Armored Regiment, the 4th Infantry Division, and led critical work to build resilience in that group. It was great to hear from those veterans how access to care and support from peers impacted their journey through recovery. And it is these stories that keep me focused on the work at hand. I am pleased to talk about VA's continued partnership with the Department of Defense. Our collaboration with DoD personnel and readiness leadership is critical to our success as we continue to examine how best to address suicide prevention across our entire military and veteran community. We are jointly committed to reaching those who have worn the uniform where they live, work, and thrive. Already, we have worked diligently on a number of important collaborations to reach people at risk of falling through the cracks, bolstering support for service members as they transition out of service and facilitating their access to care. And yet we realize there's so much work left to do. We look forward to this continued partnership. Suicide is a serious public health tragedy. It affects communities across the nation. In the United States alone, we know that there are 123 people that die each day by suicide. And more globally, 800,000 people die by suicide. That's one person every 40 seconds. And we know inside the VA that on an average of 20 people who've worn the uniform die by suicide. This is a figure that has remained relatively stable over the last few years, but that has not stopped us from learning everything we can about the data. Of those 20 tragic deaths, we know only 6 have accessed VA health care in the 2 years leading up to the death by suicide. The majority, 14, have not. And when you look at this data even closely, and Chairwoman Brownlee already mentioned it, 2 to 3 of those individuals that have died by suicide are former National Guard and Reserve members, never federally activated. And if you account for the one other that's on active duty status, you come to the 4 that the Chairwoman mentioned. This issue cannot be solved through mental health care alone. In fact, national data shows that more than half of Americans who die by suicide in 2016 had no known mental health issue at the time of their death. And this is also true for our veterans. A massive expansion of mental health providers and a world-class mental health access has done little to reduce the total number of suicides among veterans. Maintaining the integrity of VA's mental health care system is vitally important, but it is not enough. VA cannot end veteran suicide alone. This understanding is why we have expanded our efforts into the public health approach. Our national strategy for preventing veteran suicide is a multi-year effort that provides the framework for identifying priorities, organizing our efforts, and focusing community-level resources to prevent suicide. It's intended to move us from a focus on crisis intervention to a set of bundled strategies across multiple sectors. Our readjustment counseling service is a critical element in our strategy to provide a wide range of confidential social and psychological services to eligible veterans, active duty service members, and members of the Guard and Reserve, and their families. These services are designed to increase barriers to care, such as providing services after non-traditional hours away from brick-and-mortar facilities. The Vet Centers aggressively focus on preventing suicide through partnerships, including with the National Guard and the Reserve. And the Vet Centers have consistently increased services to veterans, service members, and families. In 2018 alone, we saw that increase by 4% with an 18 bump among service members. An 8%, I'm sorry, not 18, 8% bump among service members. We are also working with federal partners, states, local governments to reach veterans and communities nationwide. In March 2018, we collaborated with the Department of Health and Human Services to launch our Mayor's Challenge. And in October of 18, we took those efforts to the state level and we launched a Governor's Challenge. This initiative allows VA to work with 7 governors, 24 local governments, chosen based on veteran population and veteran suicide prevalence rates, with a focus on all veterans, not just those that come into our VHA healthcare system. We've also recently implemented 2 executive orders. Under the first one signed in January of 18, we're partnering with the Department of Defense and the Department of Homeland Security around transitioning service members, trying to get after that first 12 months that we know is critical. We also executed a second one called Prevent, signed in March 2019, to further our efforts in this space through the development of a national roadmap. So we recognize that we must partner, empower, and engage communities to reach all veterans, not just the ones that come into VA for health care. Our objective is to empower veterans where they live, work, and thrive, whenever and wherever they are. So we thank the committees for their support of this mission, including the members of Congress who've recently helped us to spread awareness of veteran suicide through a PSA drive. Together, we know that we can make a difference. Ms. Chairwoman, this concludes my statement. My colleagues and I are prepared to answer any questions you may have for us.
Thank you, Dr. Franklin. Mr. Fisher?
No statement, ma'am.
Okay. I would like to start by asking a few questions, and unfortunately at 4 o'clock I'm going to have to leave for a meeting with the chair of the full committee, so I will turn it over to Ms. Brownlee at that time. Dr. Van Winkle, let me start off with the question of embedding behavioral health personnel within the units. Have we seen any benefit associated with doing that?
Thank you for the question. And certainly Captain Colston can talk specifically about that. I think any time that we provide the opportunity for service members to receive support, we are working to prevent suicide. We do have embedded behavioral health, mental health individuals that Captain Colston can talk about. We also embed military family life counselors to provide support, and we allow for surge capacity if there has been a suicide in the ranks, that we provide more military family life counselors to support the unit at large. And I can turn it over to Captain Colston to talk about the embedded behavioral health.
So, ma'am, we embed behavioral health both into primary care clinics and into line units. I found in...
How many? Can you tell us how many you have in the line
Of the
units?
10,000 providers, it's over 1,000 right now, ma'am.
In units?
Yes, ma'am. Or in primary care clinics. So we have 10,000 providers right now. It is really useful. In some ways, it's a loss leader because, of course, you're not seeing patients in and out in the clinic all day, but it really speaks to what Mr. Kelly spoke about, and that's interaction with those line commanders. That's vitally important, and really getting a pulse of the unit. I found that my interaction with both commanders and chaplains in a deployed setting was really, really important. And it's something that we've endeavored to get into doctrine and standardize and optimize.
So I was stunned to find out that there is such a high percentage of those who commit suicide who've never been deployed. So what can you say to that?
So just historically, in what I've seen, over 40% of people who commit suicide haven't deployed. They're white, they're male, they have GEDs or high school degrees, GEDs, and they're enlisted. The suicide rate in folks with GEDs was over 50 in the last DODSR in 2016. One thing that I've seen over my service, and I was a line guy before I was a doc, is we've really tried to treat people on station. We used to separate over 4,000 people a year for personality disorders or adjustment disorders under that type of rubric, a non-medical separation. We've reduced that to 300 per year. And I think that meeting people where they are, meeting those needs is going to be part of the suicide prevention equation.
Have you, in your evaluation of this population, determined what percentage of those that commit suicide in basic training?
It does happen, ma'am, and certainly I've seen it. It's a very small number. And the only reason that it's a small number is because there's a great deal of supervision in basic training. And there are specific procedures in basic training. For instance, if you have a headache, you're only going to get 10 Tylenol. You're going to be monitored by your squad leader, things along those lines. It's the A schools and after that we really struggle.
And can you provide any light on the fact that there's a higher incidence of mental health services in the last year of service?
Yes, ma'am. Our DMDC records show that about 25% of folks avail themselves to care in the year before they leave. I think that's a good number in as much as it helps for continuity of care with our VA partners, but it also speaks to an opportunity that we missed, perhaps, in why didn't they come in earlier if they were struggling, or how was care stigmatized in a manner that made it hard for them to seek care earlier?
And have you asked those questions?
Oh, certainly, ma'am, and I've certainly asked them as a clinician. You know, I think one of the things, let me just bring up an example. The incidence of depression in women is about 33%. And I've spoken to many women right before they leave service, and, you know, why didn't you get care earlier? Well, you know, I think that care was stigmatized for them in one way or another, and certainly we've made an effort to meet patients where they are. And, you know, just like we need to make sure that we take care of gynecological care for women, we need to make sure that we take care of mental health care for women.
Thank you. Chairwoman Brownlee?
Thank you, Chairwoman. Over the weekend, there was yet another tragedy, suicide, on the campus of one of our VA facilities. And at that same facility, it was reported, I have an article here, that reported that a veteran seeking mental health care was repeatedly at least the article alleges, was misinformed of his eligibility due to his other than honorable discharge status. So I wanted to first, Dr. Franklin, ask you in terms of the VA's efforts beyond letters, what other initiatives are we taking to ensure that our veteran community who are aware of the change in eligibility regarding other than honorable discharges?
Thank you. I appreciate the question because it is an at-risk population group. We know that when people are leaving the military in a bad way, back in the day, bad paper discharge, they would call it, is definitely a high-risk group. And we did mail out over close to 500,000 letters. And of those, you should know 3,500 have come into care. And I have the breakout in terms of those, how many have come into mental health care and or had a diagnosis. It's 1,413 have a mental health diagnosis, and the other group have come in for some form of care and or treatment. And I think that there is work to be done to continue to get the word out. So far, above and beyond just the letters, we're educating all 400 of our local suicide prevention coordinators so that they know they have a requirement to do 5 outreach events a month. So if you just do the math, over 400 of them, 5 a month at key places across a state or a community where there are known populations at risk, where they're educating community members on the fact that if people leave with this type of discharge, that they can access care and that we want them to access care. Otherwise, we're trying to hit the media with broad articles and educational spots where we describe the fact that we are open to this type of care. I don't know if Mike Fisher may have some other specific examples.
Absolutely, thank you. Our focus is also on outreach, and our definition of outreach is going out and creating face-to-face connections with those that we are trying to create access to care. About 99% of our outreach workers are fellow combat veterans, so we're able to speak that same language. Last year, we did 35,000 outreach events where we're able to create those face-to-face connections. And actually, vet centers have had the ability to provide services to people with problematic discharges for several years. And that really, we make sure that we focus that explaining that when we go out. And then also now with the updates with over on the medical center side is making those connections as well.
Thank you. And just same question to Dr. Van Winkle. Is there, I feel like this can be a collaborative effort in terms of outreach and certainly before someone leaves the military that may be dishonorably discharged. How can you help us to inform this population of veterans?
Thank you for the question. I think that as we start to work within the transition space and some of our governance structures, including the Joint Executive Committee, we have been having these conversations with the VA about how can the department work better to transition our folks and provide them all the information that they need. One of the things that we've been doing, and I've been working directly with the Veteran Benefits Administration under the guidance of the Joint Executive Committee, is to codify a transition framework that goes from 365 days prior to separation to the 365 days post-separation. And the goal of this is to make sure that service members leave the military with an understanding of and easy access to all of the benefits and resources that they require. And this includes those subpopulations who may have been other than honorably discharged or dishonorably discharged. We are considering those subpopulations and making sure that the Department of Defense and the VA has the burden to get this to a place where they have that access, that it's not up to the service member to have to do the legwork to figure out all the different resources available to them. So this is something we're working on and the Joint Executive Committee has taken on.
Thank you. I wanted to ask another question. This is with regards to MST, and there's been peer-reviewed research that repeatedly finds that the experience of MST elevates the risk of suicide, and the risk is even higher for MST survivors who are also members of marginalized groups, women, racial minorities, LGBTQ service members. So, and over half of the service members who report MST experience retaliation by their chains of command. So this is I know it's a question that is always asked, but I think we have to keep asking it because it's such a huge cultural change within the military. But what are we doing to help to create that environment in the military to make it safe for survivors and really safe for anyone to reach out for help?
So I appreciate that question as well, considering my position where sexual assault policies and the suicide policies both fall under me, as well as the policies on harassment, hazing, bullying, drug use. And the reason being is because we know there's an intersection between all of these behaviors. And when you have an individual who's experienced a sexual assault, this is extremely fragmenting and shattering, and often they may cope by drinking more or having other experiences which will put them in a place of experiencing depression and potential suicidal ideation attempts. We work within this space on the policy level under the Prevention Collaboration Forum, which I run, where all of these policy offices work together to align our prevention strategies so that we make sure we close any loopholes for those individuals who may be experiencing multiple issues at once. In the Prevention Collaboration Forum is also the Family Advocacy Program, talking about domestic violence, the care that we provide to our families and to our children. And that is one of the structures that we use in order to address these co-occurring issues. Captain Colson also can talk a little bit about the behavioral health treatment targeted towards these individuals.
So every evidence-based treatment for sexual assault trauma is available in DoD. Cognitive processing therapy, prolonged exposure therapy, which is an especially good therapy from Edna Foa's lab in University of Pennsylvania, medication, and certainly wraparound services for these folks.
I'm convinced that there are lots of programs and supports around there. I'm still just continue to be concerned around the environment. I just think there is a lot more. I hear it anecdotally time and time and time again about retaliation and the chain of command, and I just think that we have to, truly address that in a way that we are really drilling down every single place within the military, that it's just unacceptable that that would happen. And I still hear over and over again that members of the military, men and women, around mental health or MST, the fear of just reaching out to ask for help. And so I know cultural changes are really, really hard, but unless the leadership is completely committed to it, it's not going to happen. And certainly on the VA side, we have, the same kind of cultural issues that, that we have to address. So I feel like I've never been in a committee where the chair people weren't limited by time. So I want to be respectful of the time, so I will yield back.
Captain Colson, along those same lines, I visited a VA program in Menlo Park for MST survivors. Not one of them was going to be able to leave the program and go to a home. They were all homeless when they were going to leave the facility. And I'm also concerned that for a long time, I don't know if we're still doing that, and maybe one of you can enlighten us, many of them were discharged with what was called a personality disorder. And I'm curious whether or not they were, in that status, able to access services.
So they got, under that rubric, they got a general discharge. But we did make a very large effort to address injustices in that regard. I think that I've spoken in other committee meetings about how we've evolved around that particular type of discharge. Going from 4,000 a year to 300 folks a year. In about 2013, Secretary Panetta made a promise at Senate Appropriations Committee that we'd review all of those cases, and in fact we did. So we looked at over 200,000 instances where folks didn't leave with medical benefits, where they left less than 30% by our Physical Disability Board of Review. And the Physical Disability Board of Review, which was run by the Air Force and overseen by Personnel and Readiness, scrubbed cases over 3 years and got benefits to lots of folks. And they also did a lot of outreach. So they went to homeless shelters and looked for those folks. We have boards of correction for military records. And there is a presumption in those boards of correction that a mistake may have been made. So we've given specific guidance around those types of cases to our boards of correction.
All right, maybe for the record, you could just provide us with the numbers. If you've looked at 200,000, could you let us know how many were changed?
Yes, ma'am. I just got a FOIA request on it, so I think I have it ready.
All right.
I would ask that there be equal time, and I know that the minority party probably is not entitled to any comments whatsoever, but this is ridiculous that we have gone through many, many minutes and we've not even been referred to, and it's very passive-aggressive behavior and intentionally leaving the minority out, and this is not the first hearing, and I just ask that equal time be represented in this hearing and all other hearings.
Mr. Kelly, you are recognized, and you have as much time as you would like to ask your questions, as we always do in our committee hearings. So,
thank you, Madam Chair. Generally, it's the chair, ranking member, in all 4 years that I've been in every committee and subcommittee that I've been on. With that being said, I would first say that I'm very concerned about our reserve component service members and veterans who return to their civilian communities where there may not always be good access to behavioral health resources and the support systems you find on military installations. There's also the issue when reserve components come back, National Guard and Reserve, they don't demob at the same time. They go home to different locations. There is not that unit cohesiveness and the ability to talk with the soldiers that they serve with while they've done so. What are we doing to reach out to the Reserve and National Guard and make sure that these veterans are getting the help that they need?
Thank you for the question. We do have those concerns that you mentioned about the reserves and the National Guard. Simply pragmatically, they don't have the access to the same resources that you may have in the active duty when you are under our purview 24/7. So that is on us to make sure that we provide them all of those resources. And we do this in a number of ways. We do provide all of our resources in terms of the crisis lines and military family life counseling and peer-to-peer support that they can call in. We provide that. It's on us to make sure they recognize that that resource is available to them. Captain Colston can talk a bit about how they target their efforts to the reservists and National Guard, and Mr. Fisher can talk also about the vet centers, which are available to our reservists and our National Guard.
Thank you. One of the things that we're working on within vet centers is actually an initiative with the National Guard Bureau, where we are taking our assets, both our counseling staff, our outreach staff, our mobile vet centers, and we're going out to drilling units and spending time with them, what makes sense for them on a drill weekend. Our real job there is to go out and make those connections like we talked about before. But if they need services, connect them into services or provide the services on the ground. Now, we recognize that there will be individuals that are not truly eligible for vet center services that we meet. And if they are in crisis, we will meet that need. But our job then becomes, where can we make that referral to? Whether that's the VA or our partners in DOD, the National Guard Bureau, or other places within the community. As we roll out the National Guard, our next step then is to go into the reserve forces and do the same thing, but get connection to those locations. And really what we're doing is we want to build relationships with leadership so that when we're not there, we can create bi-directional referrals.
I thank y'all. I just ask that you look at the soldier level, especially combat veterans or like experiences, because I will tell you, many combat veterans will not talk to non-combat veterans. More specifically, that subset is even smaller, the folks, the platoon or the squad that they actually serve with. They're willing to share with those like family members when they won't share with anyone else. So that is the key to identifying the issue, is those small subsets which they will only share. Dr. Van Winkle, thank you for your work in this area. What type of training do junior leaders in the military receive to help identify behavior in their troops that may be a sign of greater behavioral health issues, specifically suicide?
There's a number of training efforts that we provide to both our junior leaders as well as our commanders and service members writ large. The idea is to make everybody part of the solution. And so when we talk about risk factors, we're looking at often situational factors that cause stress and can often predict whether somebody is going to go get depressed and go on to die by suicide or attempt suicide. Those include relationship problems, financial problems, legal issues. And so when those issues arise and a commander or a lower level leader, the first line supervisor, is made aware of it, it is a call to action that we may need to provide additional support to that individual. But we have broadened that to be the service members themselves, as well as the families, to again be part of that solution.
And I think Dr. Captain Colston, you made an interesting comment, and I can tell you in 33 years of military service and through going through PHAs and everything else that we've had to go to on a yearly basis, and also doing post-deployment stuff and seeing other soldiers do those, there's a reason that people wait till you're 19 or their last year before they report anything, and that's not just behavioral health issues, that is physical issues, and it's from the fear of being removed from the service, and that is the stigma which we must figure out how to stamp out, because they won't tell you they're hurting, they won't tell you either physically or internally, because they're scared that it will impact their career. What can we do to make sure that they disclose this earlier to remove that stigma and that fear of being removed from service?
I think the first thing is we absolutely need to get the word out that it's almost impossible to lose your security clearance from endorsing a mental health history on your SF-86 question 21. And we really have data, a couple dozen out of nearly 10 million security clearances. So when we look at the process of, okay, let's get down to the data, are we gonna kick you out for having a mental health condition? Probably not. And in fact, there's a presumption of non-disclosure with commanders. As a commander, do I wanna know absolutely everything about anybody, any of my troops? I do. But there are all kinds of things that to create an environment of trust and an environment where you can come to see me, that we need to delimit things that we speak to commanding officers about. So that's imminent harm to self, imminent health to others, severe substance use disorders. But we really need to have something that's very private between clinicians and soldiers.
And I would ask the rest of y'all submit that for the record so we can have other people answer some questions. But I would also, one thing for the record, just someone give us the information on what the disparity in percentages for women and men committing suicide. I know there's a smaller number of women, but I would love to know the difference in women or any other differences that you can do for the record. So thank you, Madam Chair.
Thank you, Mr. Kelly. And Dr. Dunn, you have as much time as you need.
Thank you, Madam Chair. Dr. Franklin, please elaborate on some of the specific changes you're making to VA's suicide prevention programs.
Sure, absolutely. We've made a number of changes in the last year that I'd be pleased to tell you about. I mean, the first is putting pen to paper on a national strategy. I think in times past, the VA's approach to suicide prevention has largely been focused on the veteran crisis line and on providing the best mental health care ever. And that alone, we know, will not prevent suicide. And so this strategy really gets after making sure that we're doing broad sector engagement and we're moving outside the four walls of a VA hospital system, which is new. Traditionally, we've, like I said, had an approach where folks come to us and we provide them the best care we can.
Do you have metrics you're following those changes?
Yes, so this is all brand new within the last year, and our ultimate metric that we've come up with on this, or the ultimate metric, is to lower the 20 a day. But left of that metric is a set of bundled metrics that we have come up with, and it's everything from making sure that we have an all-hands approach in terms of training, so a metric tied to training. We have a metric tied to increasing access to health care. We have a metric tied to our predictive analytics approach when we identify through our predictive modeling, maybe you've heard of it, ReachVet, that we get those folks into care, the high-risk folks.
Good. I think we would like to see some of that,
Absolutely.
just a white paper kind of answer at your convenience. Mr. Fisher, here's a little good news for you. H.R. 1812 that allows the Guard and Reserve to access vet centers if they've been activated for national disasters, civil disorder, drug interdiction operations, just passed the House by voice vote.
That is great news, sir. Thank you.
Now, in that vein, what percentage of your vet center counseling is provided to active duty or Guard?
Well, like the chairwoman said before, last year it was 5% of the total uniques coming in were for active duty service members. The Guard is a little less than that. But what we are seeing is increases in those two populations. So last year, we had a 9% increase in active duty service members, an 8% increase in active duty service members come in. And over this past year, as we roll out this National Guard initiative, we've seen a 9% increase in National Guard individuals coming into vet centers or connecting with those individuals.
Thank you. Captain Colston, what kind of outreach does DOD do to make sure that the active duty troops know that they can use the vet centers?
So all kinds of outreach. I think with regard to military, all types of outreach. So in regard to military sexual trauma, vet centers have long been available. We make an effort to ensure that folks know there's continuity of care, that we have a warm handoff between our side and the VA side, or our side and an ongoing TRICARE relationship, or our side and the civilian side.
I think your troops might be more interested in finding out there's confidentiality rather than continuity of care when they go to a vet center.
And I agree with you, sir, and I think that's an important part of everything that we do. And also as providers, I think there needs to be a presumption of non-disclosure.
So General Kelly mentioned that, that people are afraid to self-report, and I can tell you it's true. You don't need to hear from me. They are afraid to self-report. Dr. Franklin, understanding that public perceptions are powerful, and that one of the VA's goals is to support responsible reporting of suicide, what advice do you have for media outlets reporting on this hearing and for our audience and members sitting here today?
Yes, they are critically important, and I think the average public doesn't realize how much they can influence the suicide prevention space by safe reporting. So I have all sorts of advice. I mean, first and foremost, I don't want the general public to think that the VA is ever limiting how folks should report, but following the national safe reporting guidelines is critically important. So making sure that headlines are accurate, that they are factual, but that they don't glamorize, and making sure that we don't get into the details of the method. It's not important for the media, whether reporting out what type of the method that occurred when the death occurred. I'm hesitant to not want to say it just for the...
I understood. Do you have a bullet point list like you give?
Yes, we have safe reporting guidelines. We've just published them in the last few months, and we're trying to get them out near and far so every reporter in the nation knows. And we're also holding a media roundtable next week where we're bringing in all sorts of media outlets, and we're partnering with the national entities in this space to really just do an increase awareness and try to help us get it right session.
I would once again appreciate sort of that in written to the VA
Yes,
Health Committee. We'd be grateful. And Madam Chair, I yield back. Thank you.
Thank you, Dr. Dunn. Mr. Gallego, you're recognized
Thank you.
for 5 minutes.
Thank you. Captain Coulson or Dr. Van Winkle, I know that service members own firearms at a higher rate, and they come, of course, in contact with guns more regularly than the general population, and that guns are the particular preference in terms of use for deadly suicides. Are there red flag powers the DoD has to seize guns from service members if they are deemed a risk? Obviously not the weapon you take out of the armory, but when I was in the Marines, even on base, you were allowed to carry a personal weapon provided you told your command about it.
Thank you for the question. And Captain Colson can talk a little bit about how commanders work with behavioral health folks to make sure that they're making good decisions within this space. Firearms are part of the conversation only insofar as they are the most common method by which a suicide will occur. They are the most lethal means by which you can attempt a suicide. Certainly commanders have a responsibility to protect the military members under them. If somebody is showing signs of imminent risk to themselves or another person, we always want to make sure that we take action across the board. And it's not only firearms, prescription drugs, any other method, but it is not done in exclusion of working with behavioral health individuals.
And in regard to safety and care of service members, of course, commanders have an abiding interest in that. And as a psychiatrist, most of the time that someone's acutely suicidal, that precipitates an admission, an inpatient psychiatric admission. Developing rapport with folks and rapport with commanders is really important to execute that. Certainly in policy, we have things along the lines of command-directed mental health evaluations. You know, certainly a young male patient who's acutely suicidal and has a weapon is someone that you're concerned about clinically.
I guess, you know, what I'm asking is if there's a formal process for this. I'm sure some commanders understand that, you know, they have the right to do it, but is there some formal process or training that you could give to these commanders saying, like, if someone is suicidal, please, you know, inquire about if they have a weapon in their dormitory or whatever they have? Just because I feel, at least on the private sector side, what I've seen that has been successful when family members have identified people that are potentially suicidal, that they take their weapon away from them until they're stabilized again. And I'm just curious to see if, at least on the on-base side, if there's something of that nature or some program we could teach these commanders to the process to go through.
So means safety is part of all interactions with command, not only weapons, ligature risks, sharps, medications, things along those lines, and it's just part of the way that we do business.
Right. And there's, is there any type of data that has been collected for us to be able to tell whether members of the military that saw combat have higher rates of suicide or just lower rates of suicide? Because I've seen conflicting data.
Well, you're absolutely right, Congressman. So the data are conflicting. Rieger et al. Did not find a nexus between deployment histories and subsequent suicides. There was a recent study, a STARS study, an Army STARS study published by Ursano et al. That said for folks who had deployed exactly 2 times, folks who deployed before the 12-month point or had less than 6 months of dwell time had higher suicide rates.
And I guess this just has to be just purely asked, what is, in your opinion, the cause of the higher rates of suicide that have just has occurred in the last year?
I got to give you my very honest answer, Congressman, and that is
we appreciate that in Congress once in a while.
I do not know. Obviously, there is a disturbing secular trend. We have seen our suicide rate double between 1999 and 2016, while the secular rate increased 25%, increasing in every state. You know, when I was an intern, suicide rate was low. There was military service was actually protective for suicide. So obviously some set of circumstances have changed.
Right.
One thing I'd say about suicide is there's over 300 separate forensic risk factors for suicide.
Dr. Van Winkle, do you have an opinion?
So I would concur with my colleague that when we're talking about suicide, it is an intersection of a variety of factors that are social, biological, psychological, that operate at the individual, community, societal levels. It's fairly complex and often difficult to determine exactly what is occurring within a whole population and even within subpopulations where I think there are unique considerations.
Thank you. Thank you, Madam Chair.
Thank you, Mr. Gallego. Ms. Radewagen, you have 5 minutes.
Talofa. I represent American Samoa, and we have a very high percentage of veterans in our beautiful islands. And we will have perhaps even more in the future because we have such a very high enlistment rate in our armed forces. And you know, it just breaks my heart to think of any of our veterans losing hope or struggling alone. The problem of veteran suicides is a national tragedy, as we all know. And I do want to thank Chairwoman Brownlee and Ranking Member Dunn for their ongoing efforts on this issue. I also want to thank Chairwoman Spire and Ranking Member Kelly for holding this joint hearing, and I want to thank you and welcome the panel, everyone here, for their work on behalf of veterans. A single veteran suicide is too many, and it's my hope that we can make some real changes this Congress. My question has been partially answered, but let me first direct it at Captain Colson on behalf of DOD, and then to Dr. Franklin for the VA perspective. Now, as I understand it, mental health is as complicated, if not more so, than bodily health, and varies from patient to patient. For example, Some individuals respond well to pharmaceuticals, while others can suffer adverse side effects. You may have touched on this in your statement so far, but could you please elaborate on the different types of treatments that each department makes available to service members and veterans? And what systems or procedures do you have in place for identifying whether a treatment option isn't working and adapting care to each individual patient's responsiveness?
Thank you, Congresswoman. Well, first of all, we have a behavioral health data portal. So we measure outcomes on folks in regard to whatever the treatment regimen is. So for suicide, there are many approaches. There's cognitive behavioral therapy, there's problem-solving therapy. You can treat underlying depression. As a psychiatrist, I see severely mentally ill people, so people with schizophrenia respond to a drug called clozapine. There are probably 12 evidence-based treatments for suicidal folks. The thing that we struggle with is they all have really small effect sizes, so you need to treat a lot of people to really help one person become less suicidal or, in fact, not commit suicide. So establishing a nexus between our treatments and a decrease in suicide has been extremely hard, and at the population level, we just haven't seen a signal yet.
Dr. Franklin?
Yes, the good news is that we use the same treatment methodologies as the DoD. So we train our providers together. We have annual conferences and annual mini residencies where they're trained on the same set of evidence-based practices and protocols. And so that's, for what it's worth, part of the story in terms of how we train them on the evidence-based practices that Captain Colston spoke about. From there, in terms of the latter part of your question, which was really tied to how do you know what you're doing is working, we have a system in place similarly to this behavioral health portal that the captain mentioned that gets after quality reviews and monitoring sort of up the chain. And that occurs at the very local level in supervision between clinicians and mental health leadership, and then is monitored all the way up to VACO to make sure that the evidence-based practices are implemented with a high degree of fidelity to the model, sort of making sure they're implemented the way they were designed, the way that we know will produce the best results and get the client going in the right direction and relief of symptoms. But Captain Colston's absolutely right. The efficacy is difficult over time, and the work needs to continue in this space. And I further offer that is why we need to focus on additional capabilities in the fight for suicide, because the mental health work definitely is essential and needs to continue. And we need to make sure they leave our offices with the veteran crisis phone number in hand, but then they need life supports. Throughout the course of the week, we need to make sure that our veterans are employed, that they have homes, that they're engaged in meaningful and life that brings them purpose and passion, and that they have the supports to thrive during life above and beyond their mental health therapy.
Thank you, Madam Chair. I yield back.
Thank you, Ms. Radewagen. Mr. Cisneros, you're recognized for 5 minutes.
Thank you all for being here today. Dr. Van Winkle, first, how much funding does the DoD dedicate to suicide prevention research?
So I'd have to take that question for the record to get you an accurate number on that.
All right. Dr. Franklin, could I get that same question? How much does the VA dedicate to suicide prevention research?
Just research, I would have to pull the thread on that as well and get it back. I have the entire budget here with me, but just research I need to pull.
Okay, I'd appreciate that.
Yes, sir.
Thank you. What is the process, Dr. Carlson, or Captain Carlson, you asked, you said there was a handoff. Well, actually, let me go back and ask this question. When an individual is, whether they're coming back from overseas after serving in combat, or they're getting ready to separate from active duty service, what is the process for helping to identify whether or not they're suffering from PTSD or some other mental health issue? Are they self-identifying, or do we actually have a process to figure this out?
Well, both, sir. So the DoD cohort is the most screened cohort of folks in human history. So you will be asked about suicidality, PTSD, depression, and generalized anxiety disorder in a periodic health assessment, in a separation health assessment, and you'll also be asked it every time you go to the primary care doc. So when I just went to Walter Reed, all those questions got asked. So that's one opportunity where you're self-identifying through screening. But it's also DoD policy that there's a warm handoff between clinicians. So you have an obligation as a clinician, including as a deployed clinician, to make sure, because we're all using the same health system, and I have access to the electronic health record as a deployed physician, to do everything that you can to make sure that there's a clinic-to-clinic handoff, if not a provider-to-provider handoff.
So once an individual is separating, and you talked about this warm handoff, when they're getting out, they're no longer seeking or getting DoD military health care, and they're going to the VA. How is that handoff being done from DoD to the VA to making sure that that individual is going to continue to get care? Because one of the things that really does disturb me is a number of those individuals that are killing themselves out of that 20, 20 per day, are not seeking VA health care. So how are we doing this handoff to make sure those individuals continue to get care?
Well, first of all, we need to meet the patients where they're at. So they need to continue the type of care that they want to continue. A number of my patients who have severe mental illness will continue care at a high level, so psychiatrist to psychiatrist. And that would include a discharge summary, making sure that our formularies are aligned, which they are, between DoD and VHA, making sure the patient has enough meds when he goes to the next place. But the folks who the predominance of suicide risk in the population is in folks who are less mentally ill. And in fact, we need to meet those patients where they're at, whether that's in credentialed health care or, like my colleague, Mr. Fisher, in confidential health care in vet centers or elsewhere, or in community-based health.
Well, yeah, Dr. Franklin, how do you receive those individuals that need that health care or need that mental health care coming from the DoD?
Certainly. There is a program in the DoD called In Transition, and this is a capability that recognizes when people are on active duty status and they have a known mental health problem, they fall into this program. It's one word, the title of the program, In Transition, and this is a program that then carries them through over to the VA with frequent caring outreach and contact, where they're getting actual phone calls and coached into the VA system above and beyond this process that Captain Colston talked about, which is provider to provider across DoD to VA. There's also this additional safety net, they call it, of this In Transition program. But I think what you're getting at is this other part of the population that ties back to this other question that was asked earlier, which is when we have a known population that doesn't get mental health care over the course of their whole career and or doesn't unpack it, doesn't have a known mental health problem at the time that they leave, they don't fall in transition, they don't fall clinician to clinician, there's no warm handoff because they're not known, then they leave the DoD and then life circumstances happen, unemployment, childbirth, divorce, good and bad that are stressful, and then the challenge is getting them into care at that point, if that makes sense. And I think that's where we could do better. We have work to do in that space, I think.
All right. Yeah, you know, one of the worst things I had to do in my military service was to go home, or not go home, but to go to a mother and tell her son that he had committed suicide. I feel for these families that are doing this, and those individuals are going through this, so we need to figure out what the problem is and get to that. So thank you very much. My time's expired.
Thank you, Mr. Cisneros. Mr. Getz, you're recognized for 5 minutes.
Thank you, Madam Chair, and I want to thank the chairs for coordinating this hearing. I represent the district that has the highest concentration of active duty military and one of the highest concentration of veterans in the country, and so this is very much a kitchen table issue in my district. My first question, Dr. Van Winkle, is what do we know about the percentage of veterans who commit suicide who struggle with opioid addiction?
I'd have to take that for the record unless Captain Colston has those numbers offhand, but I will say that the drug demand reduction program falls to me. So we certainly have ongoing concerns about opioid use within the military.
Would anyone on the panel disagree with the conclusion that opioid addiction contributes to suicide?
I would agree with that, Congressman.
You would agree with that?
The prevalence of opioid addiction in active duty military service members.
What's our current most effective strategy to deal with opioid addiction?
Medication-assisted therapy, buprenorphine, methadone, or naltrexone.
So more pharmaceutical drugs. You know, let me ask this question. Will access to medical cannabis reduce veteran suicides?
In my view, there's far more research to be done, so there is insufficient evidence for or against that position.
Are you unpersuaded by the evidence by the National Academy of Sciences citing examples in Minnesota and other states where access to medical cannabis reduces the prescription rates of opioids and the use of Schedule I drugs broadly?
Well, certainly we're open to all types of research.
Okay, so you said more research needs to be done. What is that?
Well, first of all, there are over 300 psychoactive substances in cannabis sativa. So
How many psychoactive substances are in the medical therapies that we're using to replace opioids?
there are no cannabis sativa.
No, not cannabis sativa, but psychoactive substances.
So the three psychoactive substances are methadone, which is another opioid, a long-acting opioid, buprenorphine, which is an opioid agonist-antagonist, so it's an opioid that essentially you can't overdose on, and naltrexone, which is an opioid antagonist, which in essence takes the drug off of the brain receptors.
Right, so that is the current off-ramp for opioid addiction that we use. What evidence do we have that that is a more effective off-ramp than medical cannabis?
I just think those are the three evidence-based therapies right now that meet the medical bar. Obviously, more research can change that.
How would you describe the VA's approach to researching the extent to which medical cannabis could be an alternative off-ramp for opioid addiction? Because clearly what we're doing now isn't working.
Well, there's certainly no prohibition to any research around medical cannabis, and in fact, there are two chemicals, or there's a chemical in CBD that's used for two pediatric seizure disorders right now.
So at the VA, at a local VA, can a physician recommend medical cannabis if it's in a state where those recommendations are permissible under state law?
I'd defer that question to my colleagues.
No, they cannot at this time. There's a federal law against it right now.
Right, so federal laws prohibit, do those same federal laws that you cite that prohibit prescription prohibit research?
No, they do not.
So you're saying that the VA is willing to engage in this research, willing now to post what federally approved clinical trials are available? Would the VA be willing to do that?
We have two ongoing research studies going on right now in this space, and so I think we are open to research, yes.
So the question is, does any existing law prohibit the VA from publishing what federally approved clinical trials are underway or seeking participants?
You know, I'm not a lawyer, so I don't know about the federal law that may...
Is there any law of any kind that would prohibit the VA in any way from publicizing what federally approved clinical trials are available in the cannabis space?
We'll probably have to take that for the record. I'm just not 100% clear on the exact laws.
Yeah, I don't think anybody's clear, which is the source of my frustration, because I think that there are a lot of these clinical trials that are seeking veterans. The VA, due to a lack of clarity, won't publicize that information or make it available, and then we're unable to do the research that Captain Colson says is necessary to advance additional options for veterans trying to get off opioids and to stop them from killing themselves. In my district, there's overwhelming anecdotal evidence that when they're given the combat cocktail, when they're given heavy barbiturates when they come home, they're more likely to trip into addiction, and if they have other therapies for PTSD or to alleviate that addiction, that it's helpful. And so I'm very interested in getting that. And Madam Chair, I have a unanimous consent request that the op-ed written by our colleague Congressman Seth Moulton in the Washington Examiner entitled "Let's Talk About Cannabis in the VA," in which he details 3 bipartisan bills that he and I are sponsoring to advance the work of the VA in the areas of research and medical cannabis.
Ordered.
Yes, sir.
Thank you, Madam Chair. I yield back.
Thank you, Mr. Getz. Mr. Lamb, you're recognized.
Thank you very much, Madam Chair. I do want to address the opioid topic first, and thank you all for your participation, especially Dr. Franklin, who we've had the chance to see and hear testify and meet with several times. You've brought a lot of energy to this office and this position, so thank you for that. And we look forward to working with you on this going forward. On the opioid issue, I would say, Captain Colson, would you agree that we do have plenty of evidence that these 3 drugs that you talked about that are provided as medically assisted treatment, we have plenty of evidence that they work. First of all, just the model of how those drugs act on the brain compared to the opioids that were being abused is part of why they are used and used so successfully. Isn't that right?
Yes, sir.
Okay. And I would actually say that from where I sit in Western Pennsylvania, where the opioid crisis has really hit hard, The problem is really access. It's not that we don't know how to treat these people. You know, I have a friend who's a treatment provider who has told me if you are able to combine medically assisted treatment with some of the more traditional counseling and group-based therapies for folks, you can move the needle of survival and the ability to quit the addiction maybe from 10% to 25% or 30%. You may not save everyone the first time, but you're going to dramatically increase the odds that someone will survive and beat this disease. Have you seen something similar?
Yes, sir, that's absolutely true. So, and you know, we've certainly on the federal level done things to make it easier for prescribers to get buprenorphine in the hands of patients, and I think that's been, you know, a successful public health effort. Probably one that's equally successful is the ability to get naloxone in the hands of first responders, and in fact, cops and firefighters have saved numerous lives in this scourge. 47,000 opiate overdose deaths in America last year, 47,000 suicide deaths. These are national scourges that are on the order of swine flu.
No, you're absolutely right, and it has been a great success. We've in our part of the world, we've had some of the highest death rates of anywhere in the country, and this year, for the first year, we're seeing reductions in many of the places that were the worst in deaths. I would say probably almost completely due to the increase in naloxone. Again, because the more complicated and sustained forms of treatment are not yet available. However, the VA provides it, and the VA can make this accessible to people who otherwise wouldn't get it. I served with a Marine who came off of active duty addicted to a painkiller because he had been hurt in some training right before he left. And I don't believe he was medically discharged. I think he just sort of got through the injury and then left the service with a normal discharge. But he still carried with him the addiction to the opiate. And he went home and became addicted to heroin. He showed up at the VA in Pittsburgh after having enough self-awareness to realize he didn't want to die that way. And at our VA, they gave him 30 days of detox and treatment and then moved him over to the other VA for another up to 6 months of treatment, ongoing therapy, and they actually gave him a place to live. He stayed there, and it's amazing. They had a community. They had a little rank structure. He was like the vice president of their group of folks that lived there. And I learned all this because I just went to the VA for a normal tour and ran into him. I hadn't seen him in like 6 years. So I always sort of hold up the VA as an example of the fact that we do actually know how to save people if we make the right treatment available. It just takes a really long time, and it's expensive and difficult, and it may take more than one round. So the only thing I wanted to ask about that was, for this guy, I'm not aware of whether any information was shared from DOD to the VA about the prescription painkillers that he received as a risk factor. And I know, Dr. Franklin, you mentioned in transition, which sounded like from what you said had to do with people who are actually receiving treatment on active duty for a mental health condition. Do we have anything right now that would have constituted a warning from DOD to VA, here's a guy who received heavy dose of painkillers, someone might want to check once he gets out if he's enrolled in VA healthcare yet?
So in the last year, DOD takes part in PDMP, Prescription Drug Monitoring Program. So now that flashes for everyone, and it's an incredibly powerful tool, especially, as you mentioned, General Kelly, for Guard and Reserve folks who were getting civilian care somewhere. Now I'm able to look and see what their opiate history is. And a lot of times you don't get endorsements. You don't get someone who says, yeah, hey, I'm struggling right now. So it's been an incredibly powerful tool, and it's one that we really only had online for about 9 months, but I think will save lives.
Thank you. And very quickly, time's expiring. Dr. Franklin, do you know, for someone like him, if he had never showed up for VA healthcare on his own, is there any way right now for VA as an institution to know about him and know either for the VA or the Vet Center or someone to sort of reach out and say, hey, you might want to enroll here just to make sure everything's okay?
You perfectly described the nexus of our issue. We need to get out there and find those people and get them into our service delivery, whether that's through our suicide prevention outreach people that do 5 outreach events, our Vet Center outreach efforts that get outside the gates, our homeless outreach coordinators, our veteran justice. I'm not sure if he was involved in the court system, but we have justice outreach. It's all hands on deck. We've got to find these people and do everything we can to wrap our arms around them.
Thank you. And Madam Chairwoman, I yield back. Thank you.
Thank you, Mr. Lamb. Mr. Barr, you're recognized for 5 minutes.
Thank you, Madam Chairwoman, and thank you to Chairwoman Brownlee and Chairwoman Spire for your leadership, and also Ranking Member Dunn and Ranking Member Kelly. Thank you for hosting this joint hearing. I think it's excellent to continue to shine the light on this national tragedy of 20 suicides a day. Let me start with Dr. Van Winkle. Since I haven't had the benefit of your testimony as a member of the Veterans Affairs Committee, I do want the DoD perspective here. As we're nearing 20 years of engagement in Iraq and Afghanistan, our longest engagement in U.S. history, it's my understanding that soldiers, particularly those in the Army, are deploying longer and for multiple deployments. As the director of the Office of Resiliency, how is your office taking into account the effect of these multiple deployments on service members and their families, these long deployments? I know it's very, very difficult for a lot of the veterans in my district.
Thank you for the question. It is certainly something that we're tracking, and with our collaborations with the family programs, we also track the impact on the families, understanding that that's an additional stress when the military member is overseas or deployed. Within the suicide space, as mentioned, there's no simple and direct connection between suicide and deployments at the aggregate level, but what we know is this is an individual stressor, that for some, when we talk about suicide as a combination of individual factors that we're tracking, this can certainly be a stressor that impacts them negatively. And so part of our work is certainly within the behavioral health side and within our leadership to have those conversations about the impact of deployment. And Captain Colston can talk a little bit more about how the deployment and the behavioral health work together.
One of the things that I just want to emphasize is we really make sure that we embed mental health care on deployments. So at the division level, there will be a psychiatrist deploying with the unit. And in fact, that's important because 18 to 25-year-olds often struggle with things like not just suicidality, but first break psychosis, first break mania, things that are dangerous in folks who are there to kill the enemy. So it's vitally important that we do that.
Well, thank you for that, and I appreciate the DoD paying attention to that. Obviously, operational tempo could play a role in some of the suicide issues. Our colleague, Brian Mast, who, of course, is a combat veteran, wounded warrior himself, he approached me last Congress with an idea and legislation to require an oath of exit so that service members service members obviously who are part of a team, part of a unit, a band of brothers who have who feel a strong sense of loyalty to each other, would basically take an oath upon a transition and discharge to each other that before they would cause harm to themselves, they would at least contact one of their former brothers in arms and let them know in advance. I thought that was a good idea, and my understanding is that DoD has kind of taken on that idea. Is that a good idea? Is that something that DoD is considering, an oath of exit, so that men and women, service members who leave the military are pledging an oath to each other that before they take their own lives or before they harm themselves, they will contact one of their former soldiers or sailors or airmen?
Well, I think in regard to all issues around safety, certainly, for those of us that have deployed, we met our affiliative needs with those folks that we were in the barracks with, that we were out in the field with. So yes, I think in regard to things like safety planning, which we do for suicidal people, that's a critical part of it. Telling your brothers and sisters that you're in pain is an important part of, what we do.
I think that's something we ought to pursue. Finally, Dr. Franklin, you've talked about the in-transition program, but let me talk specifically about medical records. I know we've increased a real effort to have that interoperability between medical records, but if a service member commits an act of self-harm or attempts to commit suicide while in the military, how is that information or medical documentation of that transferred to the VA?
As we stand right now, not under the new system is what you're asking me. That if they've made an attempt, harm to self, harm to others, it's in their medical record and it travels with them as they leave the DoD over to the VA side through all the methods that we've discussed earlier.
Do we have confidence in that we're catching all of that?
I have quite a bit of confidence in it, but I'm happy to also do a review if that's something that would help, like just to do a random review. I can work with our DoD colleagues to scrub that.
Well, thanks. My time has expired, but obviously it's critically important that as a soldier or sailor is passed on to the VA, that their history of suicidality would be also transferred with those medical records.
One of the highest risk factors for suicide is a prior attempt, so absolutely.
I yield back. Thank you.
Thank you, Mr. Barr. Ms. Davis, you're recognized.
Thank you, Madam Chair, and thank you all for being here. I'm sorry I missed your testimony, but I think I have a sense of all that you've been trying to do lately. And a lot of that has to do with how well we connect in terms of the interagency, intra-agency, and what you see on the horizon. What is it that you have felt you haven't been able to move forward with? You've talked about you're aligning prescriptions and some of the issues about trying to catch individuals who might be really at risk. I'm just wondering what is it that you feel has been a bit of frustration, and maybe I can share with you, I believe Dr. Franklin is familiar with some friends of mine actually who have been very engaged as parents in trying to be proactive, trying to find kind of a key, if you will, to keeping families, parents particularly, engaged with the recruitment, with the service, with the deployments and back home again transition, so that they're more aware and can be more helpful to a loved one who may be a suicidal risk. And how are we doing more in that area? Are we just so prohibited because of privacy regulations that it's really difficult to do that?
So I can speak to that latter point. We have been working with family members on a network of support, and I can provide you more information about where we are on that. But we know that one of the protective factors is simply the feeling of connectedness, often within the unit, but also ensuring that family and friends understand the military experience in a way that they can support the military member. So we have been working on the network of support option. And I can take for the record where we are with that.
Anybody else want to comment on that?
I do continue to maintain contact with the Summers. Thank you very much, Chairman Davis, for introducing them to me so many years ago. I definitely appreciate it, and I probably hear from them once or twice a month. And lived experience is important in making sure we learn everything we can from moms and dads and brothers and sisters. And the DoD and the VA has a joint panel now since we've last spoke called the Lived Experience Panel, where we collectively bring leaders together and we pulse parents and survivors just to make sure our policies are right. Are we doing everything we can? Is there some small thing that a mom or dad could teach us so that we could do better? So that's important. In terms of the first part of your question about what gives? What are your challenges that remain? I just offer to you that we've talked in the panel today about how complex suicide is, and it does call for bundled approaches, and it calls for them at full force over time, like full throttle, like we've got to move out with educating every single family member in the nation, and there are a lot of them now that I'm on the VA side. There's 20 million veterans, and they all have family members, and making sure that we have wrapped that into our protocol. And then just the bundled approaches have got to be pushed out over time. And I think about that in the context of leadership support. So on the DoD side, military leaders recognize their role on suicide prevention. And on the VA side, hospital leaders recognize their role. But I think there's work to be done on other sectors and making sure all leaders recognize their role and help with this work.
Yeah, thank you. And I know a lot of work has been done in identifying the fact that mental health is physical health, is everyone's health, and the need to not be intimidated by sort of this perception of stigma. And yet, at the same time, I often talk to people in the service, and they still raise those questions that families are afraid to identify. So, I think that we still have more work to do in that area as well, and I appreciate what you've been trying to do along those lines as well. how do we know whether or not individuals who are able to transition relatively quickly, whether it's in something that's totally new to them, they've had training while they're waiting to complete their service, are they doing better if they're actually in a job that they feel that they even have recently have been trained for versus they're still questioning what their future looks like? How does, I know it's a complex issue, but is that better?
Yes, those that are engaged in meaningful employment, not just any random job, but meaningful employment where they feel like they're part of a mission. And this is, I think, what's one of our most recent findings across the two organizations. We have a governance structure that we spoke about earlier. Dr. Van Winkle mentioned the JEC, this Joint Executive Council, and we've really been, over the last year, spent a significant amount of time tending to the social aspects of transition. And so meaningful employment is part of that, and just recognizing what it means to no longer wear the uniform as a community member.
And I guess also I would add quickly, because of time, is just, and also training business people to be able to identify and work with an individual as well as their family.
Those leaders, yes.
Thank you very much.
Yes, ma'am.
Thank you, Ms. Davis. Mr. Kelly's requested a few more minutes. So Mr. Kelly.
I first thank the chairwoman, but I want to thank Ms. Davis for her efforts, not only in this arena, but several arenas that are so important in military personnel. And she is such a great leader on this subcommittee in trying to get to solutions, and I just want to thank you. Second, on the PDMP, as a former district attorney, there was a time when the VA did not share with other doctors, which led to them going and getting it 2 different locations. So I thank you for that. And it helps with treatment as well as, and so I just thank you for doing that. One of the things I think that is very confusing is on Guard and Reserve, and probably one-term enlistees on active duty don't understand what their veteran status is. And I know when I demobbed in 2005 or 2006, they told us if you don't get a checkup every year, you lose your VA benefits, although I'd spent a full year in a combat zone and 20-plus years in the military before. If that's still the case, we need to change it because many of these problems don't manifest until years after. So if we're denying them because they didn't go get quite frankly, a stupid checkup just to go in every year, they've earned their veteran status, they shouldn't lose that. Is that still the case, Dr. Franklin or Mr. Fisher?
I turn this over to Michael Fisher. Okay.
I can speak to within vet centers. So vet center eligibility is lifelong, and it doesn't matter if you're accessing it today or 15 years from now. So you can leave, you can come into services, you can exit services, you can come back, and we can pick up wherever you left off. Part of our job also is that if we identify other things together, that other benefit services that you as a service member, former service member could benefit from, is making those connections. That includes going back over to the VA medical centers, getting connected to a veteran service officer to work out claims issues so you can access the medical centers and those kind of things.
But I think you're absolutely right in terms of being onto something. If there's confusion on the status when they leave, it becomes a barrier to care and an access to care issue. And so if we inside the VA can do a better job of an awareness campaign and some educational rollout that educates people on the complexities of what their title is and what their access to before they leave in partnership with the DoD to make that access to care easier so that we're all clear, that I take that for action. So.
And I would just ask that, you know, like I said, I left in 2006, and that was the guidance we were given. And as a very high-ranking officer, as an attorney and a member of Congress, if I don't understand it, I assure you those 22-year-olds that left them probably don't. So let's do a good job. And with that, I yield back, Madam Chair.
Thank you, Mr. Kelly. And I think before we adjourn, I just had a couple of quick questions that I wanted to ask as well. Dr. Franklin, in your response to an earlier question, you were talking about the various metrics that the VA has set up. I was just wondering if you had a basic metric for a warm handoff. You know, I don't know quite how to quantify that, but you understand what I'm saying is, you know, how are we measuring that in terms of men and women leaving the military, warm handoff, you receiving them, and then it may be another warm handoff after that. But it's mainly that transition between military and the VA.
Yes, so we get handoffs from other people other than DOD, but if you are wanting a figure on total number of warm handoffs that come from the DOD to the VA by type of handoff, mental health, primary care, the like, I'm sure that we have that in our data set.
So you would have that all in your...
I believe we do, yes, ma'am.
Uh-huh. And so where do you receive other handoffs from?
So community members might refer a
I see.
veteran, VSOs, there's
And
a
do
host.
you collect that data also?
You know, that's the piece I need to check, by referral source.
Okay.
Over the years as a mental health clinician in the field, at the local level, I know that we captured it, but I need to make sure we're capturing it at the VACO level. I can check.
Great. And Dr. Van Winkle, I just wanted to know, so in a deployed setting, have any service members been sent home or to a military hospital because of a mental illness, like you would if you had an injury and you might be sent to Germany, or you might be sent back here to Walter Reed, or...
So that's a good question, and I would have to take it for the record. I think that there are certainly a spectrum when we talk about mental illness in terms of severity of mental illness and the impact on the mission and on the member themselves. Captain Colston, I don't know if you have any information.
By all means, we've air evac folks for mental health conditions, and the most common condition is actually not suicidality. In my experience, it was first break psychosis, first break mania, a lot of 18 to 25-year-olds there who had a predisposition for severe mental illness and then get in a really stressful type of situation, and it manifests.
Thank you. Do you have the data on that? Is that something that you collect?
I would imagine that it would be possible to do a dive, ma'am. I certainly don't have it on hand. I could take that for the record.
Very good. Well, I want to thank all the witnesses. I have a lot more questions, but I hope that we can have another meeting like this with both the VA and the DOD together. I know that with the executive orders coming from the President's office, there's going to be more collaboration and more articulation, I think, about that collaboration in that first year outside of the military, and I'm looking forward to hearing more about that as you make progress. But we all agree in this room that this is a real crisis, and we must make inroads. We must make progress, and one suicide a day is one suicide too many. And I know both of you sitting here on the dais are very dedicated to that, and I'm looking forward to continuing that work. So. Again, thank you for providing the testimony today, and there's no further business. The subcommittee will be adjourned.